Srikant, the YouTube live is on.
We are live on YouTube.
Okay,
Recording.
so start the recording.
We are live now.
Yeah. Done. So 2 minutes to go.
Can you hear me? Hmm?
Shireen sir, Amit sir, can we start?
Yeah, I'm ready. I think Dr. Shiran should come and then we can start.
Yes.
Any problems, just give me a ring. My phone is in front of me. I think I'll catch it. Yeah.
Okay, so I'm audible, sir?
Yes,
Yeah,
sir.
Dr. Shiran. Yeah, perfect.
Okay, are we starting now? Is it 7 p.m.?
Yes, it
Yes,
is.
sir.
Yeah,
It's
yeah,
7.
yeah. We can start.
We can
Okay.
start.
Mami,
Okay.
Yeah, you can.
Mami, over
Sure.
to you.
Yes, sir. Good evening, doctor. I, Mami Anandi, on behalf of Zydus, welcome you in Masterclass Series 2 today, in continuation to our first series, which was on basics of gastrointestinal sonography. We are happy to organize this Masterclass Series 2 in association with Department of Gastroenterology and Hepatology, Kasturba Medical College, Manipal. At outset, I would like to convey my thanks to Dr. Shirin Shetty, HOD and Professor, Department of Gastroenterology and Hepatology, Kasturba Medical College, Manipal, for conceptualizing this event series and helping us to bring an expert who is going to discuss basics of liver ultrasound. Let's welcome our speaker, Dr. Amit Pathak. Dr. Pathak is a senior consultant radiologist and ultrasonologist, Aryavat Hospital, Meerut. There are numerous articles on radiology published in national and international journals to his credit. Moreover, he is an educationalist. He has delivered numerous educational talks on Indian history and co-authored with several books written on Indian history. We believe this masterclass will be useful in your day-to-day practice. During the masterclass, you can post your questions in the chat box. Now, I request our respected moderator, Dr. Shirin Shetty, to start today's masterclass. Over to you, sir.
Good evening, everyone. Thanks, Maima, for this kind introduction, and thanks, Zydus, for this platform. At the outset, I think greetings from Kasturba Manipal, KMC Hospital, Manipal, Department of Gastroenterology Hepatology. And I think this is the concept me and Dr. Amit Pathak were actually planning for quite some time. I think now we are into the second class of this master series on the basics of gastrointestinal ultrasound mainly for physicians and gastroenterologists and as well as postgraduates. Because we know that most of the gastroenterologists have now been, are planning to have their career in the advanced therapeutic endoscopy, including the EOS. So we need to have a basics, like a basic minimum ultrasound knowledge before we start our EOS practice. So this was our concept. So that we want to sensitize our guys. Mainly, we are targeting the postgraduate and young gastroenterologists, and we want to sensitize and tell them the basics how to go about in the hepatobiliary ultrasound. And I think for this, we have a very well-known he's actually a radiologist, but I would like to tell him that he is also a clinician who actually correlates most of his clinic cases with this ultrasound. So I think he's agreed with us. Thank you, sir. And I welcome Dr. Amit Pathak also. So this is the second of masterclass series. So we will be just talking to you about basics of ultrasound liver today. And then the next subsequent classes will be more focused on each diseases, like more of a pathology and disease-based ultrasound. And finally, we're going to have some classes on the how you translate GI ultrasound to an EOS practice. And later, maybe live hands-on training for some of the guys. We would like to do that. And without wasting time, I think I'll hand over to Dr. Amit Pathak. Maybe I request all of these guys, all of you to, post your queries or any specific questions, or you want any particular class or any details you want, you can write to us, to me particularly, or to you can send the queries so that we'll take up all these problems in the subsequent classes. Okay. Thank you. I think let's hand over to Dr. Amit Pathak, please.
Thank you so much, Dr. Shran, and so kind of you for planning this whole thing and allowing us to discuss a very important subject and a very important topic, and linked to our day-to-day practice, and actually directly linked to our field work. There are two types of work. One is theoretical work, and one while you are in the field, you're operating on ground, and then you have these investigations going on. You have patients there, and then you're planning, making decisions. So our basic purpose will be not just showing diseases by ultrasound, but also, as we had discussed earlier, to put ultrasound in the framework of disease analysis. How do we come to a diagnosis, and where does ultrasound stand in this process of diagnosing a disease when a patient walks into us? So with this in mind, we have tried to link our ultrasound program to general clinical practice, in the sense that clinical questions, issues that rise while we are doing clinical practice. And so ultrasound, not as a modality done in a separate room, completely segregated from clinicians, where the clinician only gets to see the report at the end of the day and tries to scratch his head and make out what to do with this. We want ultrasound to be part of the active diagnostic process by which we are conducting the examination of patients who come into our department. So with this purpose, we want to evolve ultrasound, and in our third world, and especially even in the first world, why not them? Ultrasound has such advantages, as we discussed in the earlier program, earlier two series, that tremendous advantages, that it's a 1-minute procedure if an emergency is there. Otherwise, also it takes a very short time. You can do it any number of times. It is real time. You are seeing the patient in front, and you are looking at what is going on inside on the machine. So it's an amazing modality, and I think we have underused it. And this is what Dr. Sharon wants, that it should get place in their time. Then what we are this today's presentation, we will continue with what we had done earlier in the last presentation, in which we had discussed the terminology of ultrasound, etc. Now, that terminology of ultrasound, we walk into liver. And in this presentation, what I have done is, through basic issues associated with liver assessment, introducing someone to liver ultrasound, we are using this terminology so that both get linked up. And with this, I think we should start with the main presentation. And I think first we'll have videos of how to approach a patient and how to go about starting a liver ultrasound examination. As simple as that. The patient is in front of you. How do you start a liver ultrasound examination? So please, I think we can start with the two videos.
Yeah, you can start the video.
We hold a pen, as we discussed in our earlier presentation. And the movement of the probe is either in the long axis or in the transverse axis. This also we discussed. Now, when we move the probe in the long axis and transverse axis, we just don't move it in any direction. Either we move in the 6 o'clock, 12 o'clock direction, or we turn it so that its upper side now moves to the right of the patient, and it is facing the 9 o'clock direction. So basically your probe is moving between the 9 o'clock and 12 o'clock direction. This is 1/4 of a circle that it takes. I will start with the left lobe of liver because that is the primary station when starting an abdominal ultrasound. So the left lobe of liver lies just below the xiphisternum. So we just go see the xiphisternum and put the probe straight down at this place. Now you can see the left lobe of liver easily. The superior part of the probe is actually on my left. So this is the left lobe of liver. If I turn the probe upwards, you can see the heart beating. And when I turn it downwards, you can see the stomach. It has got some food contents in it. And the primary axis that is there behind the left lobe is obviously the aorta. And there is small esophagogastric junction between the liver and the aorta. So this is the primary axis. Actually, this axis, even with US, first thing you see is left lobe and aorta whilst lying in the stomach, and then you define your location. So this is what we do. Now, if it turns slightly towards me, so actually in the probe, the movements are very slight, and with slight movement, because it is sweeping like this, it cuts at a deeper level in a much longer sweep. So we have the aorta and left lobe here, and I turn the probe towards me, towards the right of the patient, slightly from the same place, and what we get is the eyes. And in the left main branch of the hepatic vein going into the eyes. So this is the axis that we follow for the left lobe of liver. Now this is the long axis of the liver, and like everything else, we also have to see the transverse axis. So what we do? Now, from the left lobe, we go towards the right lobe. I am not going into the segmental anatomy of liver at the moment, because basically in this session we will do the gross anatomy as it is. Udhar karna. For the right lobe, the issue is most of the right lobe lies in this part of the abdomen behind the rib cage. You know, this is the rib cage. Whole thing is the rib cage. Rib cage extends from here. The right lobe must be lying all the way in this area, and nearly the whole place is having ribs. These are the ribs I am marking. So, how do we see the liver? Now, what happens is, right lobe, you put the probe and the ribs create shadows. This is one shadow, this is another shadow. So, though you are seeing the whole right lobe in one axis, part of it is obviously behind the ribs and is not well seen. This long axis of the right lobe goes approximately in the anterior axillary line. If you put it, turning the patient to the right, you get the whole axis of the probe of the right lobe. Many people who measure the liver actually measure it in this position, because you get the diaphragm and up to the lower end, and you can do a straight line measurement of the whole of the right lobe. This normally I do not do, but this is a technical issue we'll discuss subsequently. So what do you do to help remove the ribs? You do a similar thing as you did in the left lobe. You turn the right lobe slightly. Now this time not up to the 9 o'clock position, but maybe around 10 o'clock or 11 o'clock position, so that the probe lies between the ribs. You can see this is one rib here, this is another, and then there is one rib here. So I put the probe between the ribs in the intercostal space here. And because the ribs are now removed, you can see the whole liver parenchyma. So best is to put it slightly obliquely between the ribs and go from one intercostal space down to the next, and sweep it obliquely over the liver. And you are unlikely to miss any lesion. Now, this is the primary.
I think Dr. Patak, over to you. These were the two
Yeah,
videos.
I think, yeah. So I think now we'll go into the presentation, and for our viewers, I'd like to say that we'll be going into both the videos subsequently also. And we'll be, after this presentation is over, so that they are shown again. And part of what has been discussed in the videos will be discussed now in the presentation, which I'll be starting. So is it visible? I think, yeah. So as I discussed earlier in the video that you were seeing, that we'll start with the primary axis, long axis of the left lobe of liver. The second obvious axis is the transverse axis. So the probe was moving from the long axis with the heart up to the left of the screen and the stomach to the right of the screen. And it turns and it takes the transverse axis of the left lobe also. So all the organs that are seen in the long axis, especially the aorta and the IVC, will subsequently be seen rounded in the transverse axis. Now this for the left lobe of liver, this is the basic assessment. Long axis, then you turn the probe 90 degrees and you do a transverse axis left lobe assessment. Subsequently, as I discussed, because the liver lies between the spleen and the ribs are there, so you have to turn first of all, you turn the patient towards his away from you, and lift his right side and elevate his right hand over his head so that this area opens up. And then you put the probe initially always in the mid or anterior axillary line, whichever point you feel you can see the whole of the right lobe in one view. You put it and have a basic assessment, general assessment of the lobe at that point. I'll show you the pictures and you will know why I am saying this. After you've taken a basic assessment of the right lobe, its size, how it looks, how the diaphragm looks, how the posterior CP angle looks, then you turn the probe obliquely and move between the ribs. And then you do a oblique assessment of right lobe from top to bottom. This is the second stage. The third stage comes in, which subsequently in the later part, I'll be playing the videos and I'll show you this part also. In the end, third part, and this is very important, what you do is you turn the probe completely in the other direction, pointing it upwards. And then you see the whole of the liver coming in one view. And I'll show you the slide how on ultrasound this assessment looks. This assessment is also very good because it gives a complete view of both the lobes of the liver. Now, as I said, the first section is the long axis of the left lobe. Now, this long axis of left lobe is actually towards the right of the left lobe. Therefore, you are getting the IVC and the left main hepatic vein there. This is the primary axis. As soon as you put the probe initially, rather than the aorta, most of the times you will get the IVC first because this is the structure which is beating. And as soon as you put it in the Zephyr sternum in the long axis, the IVC will shine out in front of you. This obviously in the next program we'll be discussing diseases, so you will know that this immediately you put the probe, you see the IVC and congestive cardiac failure, and it is so common with hepatomegaly, and especially in the older age group. So this is the first section. The next section, and actually in this first section, I want to just show you the advantages of ultrasound, which are tremendous. In this first section, if you move slightly towards the left of the patient, obviously the whole of the aorta will come, and with the aorta what comes is the esophagogastric junction. So the aorta, because this probe is slightly oblique, so the whole aorta in the length is not coming like we saw in the IVC, but slightly oblique to show you the esophageal gastric junction, how beautifully it can come. So this is just to show the power of the technology that is at our hands, in our hands. Now this is the esophageal-gastric junction, and how beautifully it is seen in an enlarged image of from a very basic ultrasound machine. These images are not from the high end, in which I was doing the videos. This is a very basic ultrasound machine which will be there in every department in most hospitals and most clinics. Now what do you do next is, after you've done a long axis ultrasound, you turn the probe 90 degrees and you get a transverse axis of the left lobe. And the transverse axis, you go up to the heart and then come down below, and just before the porta you get this basic section of left lobe of liver where the IVC comes rounded and you get the whole of the caudate lobe. So this, what I call it, the caudate lobe axis, or when which segment 1 comes so beautifully shines in front of you, and this left lobe comes and the right lobe comes, and this is the primary axis of the left lobe assessment, sweeping again towards the heart and down as much as possible. When the petas comes, you stop. And that is how you sweep the left lobe of liver. And you can, obviously, I've marked out the segments that you can see. So that's part of the anatomical assessment. Now we turn, after doing the left lobe assessment, we've turned the patient and elevated his right side, put his right hand over his head, and we've taken a basic view of right lobe of liver, which I was just talking of. And in this basic view, as you can see, a normal right lobe of liver invariably comes between the screen because it is not enlarged. And people have various ways of measuring them, and this is one of those. These lines are not exact measurements. This is just to show you the basic size assessment of right lobe, even with naked eyes, that you can make out. This is the normal right of lobe of liver, and this is hepatomegaly. And you can see, if the same lines are drawn again, the liver has gone much beyond the scope of the ultrasound angle. This is the basic angle that we are using when the angle has not been increased, and you can see it is much beyond that. So this is obviously an enlarged liver. Now, personally, I do assessment of liver enlargement like a clinician would do. He touches the subcostal margin and asks the patient to take a deep breath, and he does it. I do a similar thing with my ultrasound because I don't need to feel the liver, this lower margin of liver in the hand, but I can see the whole liver. So as soon as I put the probe and extend below the costal margin and upwards, I know this liver is enlarged. And my assessment is always mild, moderate, severe. And this is just a visual assessment. My visual assessment is more important for another reason, that I always am linking the size of the right lobe to the size of the left lobe. So there is a major variation, congenital variation, in the sizes of both lobes compared to each other. Some people have a larger normal left lobe, some people have a larger normal right lobe with a very small left lobe. So it is important because you've seen a proper left lobe and you've seen a proper right lobe, and you've seen the relative sizes of both of them. So you are at a very good advantage while doing ultrasound to know and assess hepatomegaly and how severe the hepatomegaly is. Obviously, some people want me to measure it so that they can follow up on regression of liver size. That can be done, but that can be done only, that may be done only in few cases, and in every case you probably do not need to measure the liver as such. And as I discussed last time in one of the questions, size and shape of liver varies like the sizes and shapes of noses of people. Now, which is the normal size nose and what is the normal shape of the nose world over is not fixed. It cannot be fixed. Similarly for the liver, and similarly for nearly all organs that we have. So we have a very basic general assessment of liver, and size precisely matters only in few cases, especially in cases like hepatitis, where you will be following up liver regulation with time. Now, this is the subcostal view where I was talking of. You put the probe under the costal margin and elevate it, and you can see the whole of the liver, from the whole of the left to the right lobe of liver. And this is actually what you will see. And this view should be done in every case. One is, as my personal experience, that because there are no ribs or anything and you are doing it plainly through the soft tissue with nothing else, you will see lesions which you have missed otherwise while you have doing it by the other two locations. And this is my personal experience where I have missed multiple small lesions by the other location, but as soon as I did the subcostal view, they shined out. They were shined out in front of me. So this view is very important. Second is it gives you the venous pattern, and that way you are able to assess the left and right lobe, their relative anatomical locations, positions, and I don't need to give all the explanation, but any clinician will know how helpful this particular view will be for assessing the liver, complete liver as such in one view. Now we go to the subject of echo pattern and how a normal liver lives. A simple normal liver where nothing is there. Simple normal liver, two different patients looks like this. It is a standard liver, very homogeneous, very smooth. The only place where there is non-homogeneity, which is the differentiating point for liver compared to spleen, are these portal radicals, because these portal radicals will have fat at their margins. Portal radicals, this fat gives those white lines all around. So all the portal radicals give these small white anechoic spots throughout the liver, and that differentiates liver from spleen, which I'll be discussing in I'll show you a patient subsequently. The hepatic veins, as you can see, do not have echogenic walls. So this is a small branch of a hepatic vein. It is not having echogenic wall. Compared this to this portal radical, which has an echogenic wall. That is how you differentiate the hepatic venous radicals from portal venous radicals. And this is standard homogeneous normal liver. Now, when we discuss pathology, and this is a slide I borrowed from my last presentation, and I'll be following up this pattern again while discussing liver pathologies here. Liver pathology has three basic, or all ultrasound pathologies have three basic terminology. Echogenicity, whether it is white, that is more white, hyperechoic or echogenic, blacker, hypoechoic or echopoor, or anechoic, which is completely black. Echo texture is homogeneous and non-homogeneous. Homogeneous is like smooth, symmetrical, and as you saw the liver, very clean. Non-homogeneous is like, you know, the khadar cloth is non-homogeneous, and our plain cotton or silk is homogeneous. That is differentiation. Every disease will convert homogeneous into non-homogeneous. So wherever this non-homogeneous comes, or heterogeneous, there is another word used for this, is heterogeneous or altered echo texture, that means disease is there. So you can see in subsequent slides, I'll be discussing according to these points only. The last obviously is echo pattern. Echo pattern means both echogenicity and echo texture. So if you say that the liver echo pattern is altered or this mass has a non-homogeneous echo pattern, that means both echogenicity and echo texture are non-homogeneous. So the first patient is fatty liver or steatosis. I think I prefer, it's a personal preference, fatty liver. It's more easy to pronounce. You have to discuss steatosis with all the time. It actually, you turn testis more. And fatty infiltration is a very simple term which you use, though it is incorrect and actually technically, but obviously world over we are using fatty liver. So I'm using this fatty liver here. So what fatty infiltration of liver does is it makes the echogenicity is increased, whereas the texture of the liver remains homogeneous. So increased echogenicity with homogeneous texture. And the first thing that it does is these portal radicals which are there, their echogenic margins get lost. And first, initially, they get reduced. They are very faintly defined. Subsequently, they get lost completely. And this is the diagnostic idea that I use for defining fatty infiltration of liver. Then you had seen earlier in an earlier case how easily you could define the portal radicals. Whereas in this case, you are not able to see them at all. They are lost with the liver parenchyma. So this is a white liver of fatty infiltration. And you can see in this case, this on the right is an enlarged view of the hepatic parenchyma of liver, you can see the parenchyma is homogeneous. It is not non-homogeneous, it is homogeneous, but it is whiter. That is fatty infiltration, and the portal radicals, their walls are lost because this has become white and these are also white, and their demarcation is lost. This is a normal liver versus fatty liver. Again, I am showing. So increased ecogenicity with homogeneous ecotexture. This is a normal liver. The ecogenic margins of portal radicals are all gone. So this is fatty infiltration. Now, this is a relatively severe fatty infiltration, or grade 3, people say. Actually, I have never seen the diaphragmatic margin get lost. That doesn't happen. I don't know who defined fatty infiltration grade 3 as diaphragm not being identified. Diaphragm is always seen. What happens is, the liver becomes so white, as you can see in this case, that the ultrasound gets attenuated from this point. Most of it is reflected back from this point, and all this area has become black, nearly black. I've increased the gain slightly. That is why you can see these artifacts coming. And because it is such a dense liver with so much fat in it, that it was thrown off so many interfaces, that has thrown off all ultrasound back and making this whole area black. So this is a grade 3 fatty infiltration, if you want to use that grade term. It depends on the clinician. Some people use it, some you don't. But this is actually grade 3 fatty infiltration, which is severe fatty infiltration. Diaphragm is always seen, doesn't get lost. Only thing happens is it also gets slightly more difficult to define. That is what happened because of the whiteness of the liver. Now, this is patchy fatty infiltration, which is very common, especially in young people. Young boys, thin boys, they will come and they'll have this. And nowadays it is much more because people are having more sedentary habits. So this is patchy fatty infiltration. This is whiter, this is blacker, and there is a clean line which demarcates the fatty infiltrated part with the part which is having relatively less fatty infiltration or is normal. Now, this is a severe case of patchy fatty infiltration. And I tell you, with the most experienced ultrasoundologist, to say whether this is a large mass, infiltrating mass, or in a fatty infiltration liver, or this is normal liver, may become difficult, especially if the patient himself is fatty. So the ultrasound is otherwise also attenuated from abdominal fat, and then this type of picture comes in. And the best thing that you have to see is whether the hepatic veins or portal radicals are passing normally without getting shifted through this part of the liver, which is looking blacker, but actually is a relatively normal part, or part which is having relatively lesser fatty infiltration. So what we are seeing in this particular patient is there are 3 levels. One is this very white, then this intermediate level, which is also very quite white, and this is nearly normal. And you can see it has not pushed the vessel. The vessel is seen to be easily passing from a white area to a blacker area. So this is relatively normal liver in severe patchy fatty infiltration. I've got a video here to show the flow of you can see the vessel easily passing through without having any mass effect, without getting shifted. So this is severe patchy fatty infiltration. Now, there is the next thing which comes in, and this is common with viral hepatitis. And actually, it is not pathognomonic. You won't see it in all viral hepatitis, only in few cases. But if you see it, what happens is you put the probe, you see the black liver, and you know this is viral hepatitis. Even before you've gone through the rest of the scan, you know this patient, his jaundice is justified. What happens is, because there is increased amount of fluid with the hepatocytes, the liver parenchyma becomes black. And because the liver parenchyma is black, so ecogenicity gets reduced. So it is a reduced parenchymal ecogenicity, but again, ecotexture remains homogeneous. Homogeneous liver with reduced ecogenicity. Blacker liver with homogeneous ecotexture is actually pathognomonic. And in my personal private practice, maybe there are other people talking of other things, is of viral hepatitis. And what happens is that you can see these portal radicals, the fat gets accentuated because the background has become blacker. In fatty infiltration, it was become whiter. In here it has become blacker. So instead of getting lost, they have become accentuated. So this is a liver with fatty infiltration, and there is a term given to it, which is a starry-eyed appearance. And if you've seen this, how precisely that description matches up with it is amazing. It is actually a starry-eyed appearance. Now this again, you can see another case with of hepatitis, and you can see how white ring-like appearance has come over these over the radical. It's completely white, and you can see clearly white rings that are there, because this area, whole area, has become black. Now this is again reduced echogenicity, margin of portal radicals, same thing. They are appearing white, and you can see a portal radical, whole wall is white, echogenic in a line. And interestingly, in such cases, and this happens because the liver has become so black, you can see, actually literally see the portal radical. You know, this is the portal vein in the center, and hepatic artery. I have named it hepatic artery because it's more rounded, and artery is very tense rounded. And this is a biliary radical. I'm not sure whether this, unless color Doppler you apply with, again, color Doppler you'll put in such a high degree of magnification, it may not show it so precisely. But I've just done it from the appearance, because it is more rounded than this, so this is more likely to be artery. So you can see a portal triad in a case where the blackness of the liver has accentuated the whiteness of the margins of the portal radical. Next, we go to cirrhosis of liver. Now, cirrhosis there are multiple things happening. First thing is that the echo texture of the liver is becoming non-homogeneous. So in both fatty infiltration and hepatitis, we are seeing the echo texture had not changed. Whereas here the texture itself will change. And I'll show you a slide where you'll easily understand what I'm talking of. Echogenicity may be normal or may be increased. If it is from severe fatty infiltration, you have a white liver with non-homogeneous echo texture. If it is, you are having cirrhosis from other causes, though it is not precise. I have seen alcoholic cirrhosis where the liver is not white. Probably it's due to continuous processes of inflammation and coming back to normal, that we don't have a reason. I don't have a reason. But the liver, cirrhotic liver, even in alcoholics, may not be white. But one thing for sure it will have a non-homogeneous echo pattern. Secondly, its margins will be irregular. And as you can see, the size will be reduced. You can see the whole liver is shrunken up into this single image of ultrasound. And this caudate lobe, which I'll be discussing subsequently, will be enlarged. Now, this is a non-homogeneous echo texture. I have shown you the homogeneous echo textures of fatty infiltration and hepatitis. You can see this liver texture is non-homogeneous. You can see the irregularity in the whole place. This is non-homogeneous echo texture. This is a left lobe of a cirrhotic patient, which is obviously the lateral segment tends to tends to enlarge. And you can see the left lobe here has a non-homogeneous echo texture, variation everywhere. Margins are lobulated. And this is typical cirrhosis. So cirrhosis will give the non-homogeneous echo texture. This is severe fatty infiltration versus fatty infiltration developing cirrhosis. And if you compare these two sides, this is fatty infiltration without cirrhosis, quite significant fatty infiltration without cirrhosis. This is fatty infiltration with cirrhosis. So what you are getting at, increased echogenicity, but here you see the texture is non-homogeneous, whereas echo texture is homogeneous here. Echo texture is also non-homogeneous here. So this is fatty infiltration going into cirrhosis. This is plain severe fatty infiltration. So ultrasound can be quite good in differentiating and evolution of fatty infiltration into cirrhosis, obviously as one of the multiple modalities nowadays that we have. Now this is enlargement of caudate lobe, and I love this organ. This part, segment 1, is beautiful because a lot of times what happens is that the liver is normal in size. texture you are confused, and this may happen. This has happened with me all these years. And you don't know the history of alcoholism. You don't know whether this patient has developed cirrhosis or not, and if not done an endoscopy, because varices I feel to be some of the most specific. I don't know the studies, but they are very specific. This is my personal experience. But what will help you in such cases is the size of the caudate lobe. You can see two patients where the size of the caudate lobe is large, and it is actually literally bulging out of the liver. And this is the enlarged caudate lobe, which gallbladder has multiple positions. This case, it is lying like this over the IVC, and you can so beautifully see an enlarged caudate lobe. This again shows you how big the caudate lobe has become. And this also defines location of caudate lobe for people who will be starting ultrasound new. This is precisely the slide which I had discussed earlier when I was discussing the left lobe transverse section. It's just that it is bigger. This is a left lobe transverse section, left main branch of hepatic vein. This is the IVC and the right lobe, aorta, and this is the enlarged caudate lobe extending all the way anterior to the aorta. Now this is an enlarged caudate lobe, and this is a video showing it. This is the porta, CBD, and the enlarged caudate lobe. This is the bulging caudate lobe. Obviously, this patient has ascites, which helps us more in getting to a conclusion. Liver echogenicity, because there are two organs which will be adjacent to liver, and you will be obviously while doing an ultrasound comparing your liver, how it looks, how black or white it looks, with organs around. The easiest and first and normally always is the right kidney. The right kidney and liver, they say, have the same echogenicity. Their blackness is actually nearly the same. But in my personal experience, kidney echogenicity varies, because I do renal ultrasounds, only renal and gastro ultrasounds, and I work with nephrologists. It varies. So you cannot compare two variables. As you can see in this case, this is a patient with kidney parenchymal disease and fatty liver. It is difficult here to see the demarcation between the kidney and the liver. So this is a variable and this is a variable. So if you have two variables, you cannot have a comparison. You can have a comparison of only if one is fixed and other varies. Here both are variables. Fatty infiltration kidney disease, normal liver kidney disease. So these two variables don't work. So for fatty infiltration and assessing the liver parenchyma echogenicity, best is to see the portal radicals and how beautifully you see them, how brightly or are they lost. The next organ, and I tell you, for those who have not done ultrasound, frankly speaking, sometimes massive splenomegaly in liver, and you are looking in the epigastrium and you get confused, especially even when you turn the patient to the left and you are seeing the spleen and there's a massive hepatomegaly, left lobe nearly entering the left subcostal space and nearly going completely left. You are confused whether you are seeing the spleen or liver, because spleen may be pushed to posteriorly and inferiorly, and all you are seeing is the left lobe from the left side also. So this is a picture which helps you to compare the echo pattern of spleen and liver. And the best thing that we've discussed all through this talk today is the presence of these portal radicals, multiple with white echogenic margins, and spleen does not have it. Spleen is nearly completely homogeneous. Spleen has these small venous radicals, splenic vein radicals, but they are completely different. They are smaller, their walls are not as bright as you have for the portal radicals, and you can easily make out. So this is a much more homogeneous spleen and liver. You can see the echogenicity is nearly the same when the liver echogenicity is normal. And this is a video showing an enlarged spleen and liver and how you can compare them to. And this left lobe is actually reaching the entering the left subcostal space completely. There is again a beautiful picture, spleen versus liver, and you can see the portal radical and this is a venous radical. There is a difference. Spleen, I feel, is always whiter. Sometimes they may have nearly same echogenicity, but in my experience, always slightly whiter than the liver. And you can easily see that in this picture, the echogenicity varies. This is the same patient, and you can see the differentiation between this enlarged liver, left lobe of liver, and the spleen, and how they look different. They have some difference of echogenicity, echo pattern, and by the way their vessels are oriented. So this was the presentation for basics of ultrasound, how you approach, what you see. And as we are planning, and Dr. Sharon will, I think, confirm it, in the next one, we'll go into some basics of liver masses and pathologies of linked to liver disease. So Dr. Sharon, I think it's all up to you, and I think we can have the videos again.
Yes, yes. Thank you, sir. I think it was a very lucid and a very nice presentation. I think from a clinician point of view, where, I am a naive for US ultrasound I'm not a radiologist, although I do my US, but, you explained it so very neatly, because I have gone through many of the books. It was not, you made it very simple. The point is well taken. The point is the axis you need to have. You need to follow the axis. Then main thing is stick to the terminology, echogenicity and ecotexture. If you follow that, I think we can differentiate most of our normal liver, fatty liver, which is of our interest, cirrhosis, then, caudate lobe hypertrophy, then spleen. And obviously the portal vein, you told very neatly, why this portal vein lost. So I think that's nice.
Yeah, we'll mute everybody. 1 minute.
I think the other guys.
Hold on.
I think the videos can be played.
Yeah, I think we can once again play the videos. After the videos, we will take. There are a few questions, sir. Once we take up after the video, once again we'll take up those questions and some queries, and then we can conclude and we'll say what is the next plan.
Right, perfect.
Okay, we can start the videos, Mantish. Mahesh,
Yeah, sure,
okay,
sure.
Please
Yeah.
start the videos.
To hold the probe like we hold a pen, as we discussed in our earlier presentation, and the movement of the probe is either in the long axis or in the transverse axis. This also we discussed. Now when we move the probe in the long axis and transverse axis, we just don't move it in any direction. Either we move in the 6 o'clock, 12 o'clock direction, or we turn it so that its upper side now moves to the right of the patient, and it is facing the 9 o'clock direction. So basically your probe is moving between the 9 o'clock and 12 o'clock direction. This is 1/4 of a circle that it takes. I will start with the left lobe of liver, because that is the primary station when starting an abdominal ultrasound. So the left lobe of liver lies just below the Ziffel sternum. So we just go see the Ziffel sternum and put the probe straight down at this place. Now you can see the left lobe of liver easily. The superior part of the probe is actually on my left. So this is the left lobe of liver. If I turn the probe upwards, you can see the heart beating. And when I turn it downwards, you can see the stomach. It has got some food contents in it. And the primary axis that is there behind the left lobe is obviously the aorta. And there's a small esophageal-gastric junction between the liver and the aorta. So this is the primary axis. Actually, this axis, even with US, first thing you see is left lobe and aorta while lying in the stomach, and then you define your location. So this is what we do. Now, if it turns slightly towards me, so actually in the probe, the movements are very slight, and with slight movement, because it is sweeping like this, it cuts at a deeper level in a much longer sweep. So we have the aorta and left lobe here, and I turn the probe towards me, towards the right of the patient, slightly from the same place, and what we get is the eyes. And in the left main branch of the hepatic vein going into the eyes. So this is the axis that we follow for the left lobe of the liver. Now this is the long axis of the liver, and like everything else, we also have to see the transverse axis. So what we do, now from the left lobe we go towards the right lobe. I am not going into the segmental anatomy of liver at the moment, because basically in this session we will do the gross anatomy as it is. For the right lobe, the issue is most of the right lobe lies in this part of the abdomen behind the rib cage. You know, this is the rib cage. Whole thing is the rib cage. Rib cage extends from here. The right lobe must be lying all the way in this area, and nearly the whole place is having ribs. These are the ribs I am marking. So, how do we see the liver? Now, what happens is, right lobe, you put the probe and the ribs create shadows. This is one shadow, this is another shadow. So, though you are seeing the whole limb, right lobe in one axis, part of it is obviously behind the ribs and is not well seen. This long axis of the right lobe goes approximately in the anterior axillary line. If you put it, turning the patient to the right, you get the whole axis of the probe of the right lobe. Many people who measure the liver actually measure it in this position, because you get the diaphragm and up to the lower end, and you can do a straight line measurement of the whole of the right lobe. This normally I do not do, but this is a technical issue we'll discuss subsequently. So what do you do to help remove the ribs? You do a similar thing as you did in the left lobe. You turn the right lobe slightly. Now this time not up to the 9 o'clock position, but maybe around 10 o'clock or 11 o'clock position, so that the probe lies between the ribs. You can see this is one rib here, this is another, and then there is one rib here. So I put the probe between the ribs, in the intercostal space here, and because the ribs are now removed, you can see the whole liver parenchyma. So best is to put it slightly obliquely between the ribs and go from one intercostal space down to the next, and sweep it obliquely over the liver, and you are unlikely to miss any lesion. Now, this is the primary.
I think that's the two videos we had on the basics of liver ultrasound. I think we'll take some questions now. Amit sir, can you come online?
Yeah. So he's
Okay.
online, I think so.
Yeah. So there are a couple of, I think there are few questions, I think, on our box. So one is, what is the role of ultrasound in acute liver failure?
Acute ARF, acute
Yeah.
liver failure. So acute liver failure, actually, how will you define it? So I'll come to give you the exact points. ARF coming, patient coming with, what is the etiology basically? So I'll give you the points accordingly. Dr. Sharon, are you getting me?
Yeah, sure, yeah.
Yeah.
I'm just seeing some
So Dr.
questions.
Sharon, yeah. So can you define it more, because that's a very clinical term.
Yeah,
ARF.
actually, I think what he wanted to know about, I think you already mentioned about acute hepatitis.
Viral hepatitis, and that is causing, and we are getting other causes for acute liver failure also nowadays. And so basically what happens is, and will you be including alcoholic liver disease, acute alcoholic hepatitis also in that?
I think this patho, I think we will take up subsequently diseases in subsequent class. I think that was the idea. Today was mainly the basics regarding differentiating different pathologies and etiology. I think there will be a next sub classes on that. So I think you already covered about differentiating normal liver with hepatitis. I think that's already done.
But I can just add the point that acute liver disease, especially when it comes to, suppose a viral hepatitis patient comes, the first and the changes in echogenicity may take some time. So when the acute patient comes, you will invariably have an enlarged liver, and that is why he is getting the pain, because there is rapid sudden enlargement of the liver, and so severe enlargement of liver, and much more than what I have shown all these livers. You will put the probe and you will know that this liver is significantly enlarged. And what happens in, I'll be subsequently taking up gallbladder wall. And when I'll be taking, that is the magic organ with us. And when I'll be taking the gallbladder wall, then I'll be discussing the various types of hepatitis and how they manifest as various points. So as Dr. Sharon was rightly saying, this subject will be taking up in detail subsequently and in detail. So what are different levels, long-standing hepatitis, how you can see the regression of hepatitis and hepatic inflammation, and that will be taken and correlating with the gallbladder.
So there's one more question, whether chronic hepatitis and early cirrhosis, like what is the role of ultrasound? Can you differentiate chronic hepatitis just by, like you already told, I think early cirrhosis, there is a change in the echo pattern and it's not non-homogeneous. This one, I think that is answered in your slide, but maybe you want to repeat that, chronic hepatitis versus early cirrhosis.
I feel that what I was ultrasound, actually the transition sometimes is difficult to make out, because when the disease is progressing, what point cirrhosis has come in. So then the assessment becomes multifactorial, not just ultrasound. Then, because after all, every patient will be doing a multifactorial, at least basically the ultrasound, blood pathology, and an endoscopy.
Correct.
So we have, and then only after. But if you have done it, put the probe, and you can make out in many cases after a relatively good experience that this liver is going into cirrhosis, as I had shown one patient with fatty infiltration plain versus fatty infiltration cirrhosis. Second thing which I had discussed was the cirrhosis, size of the caudate lobe. Even if the liver is, you are confused with the liver, you go to the caudate lobe. It is one of the best markers. That's what I feel. Even in early cases also, it tends to enlarge. And even when the texture on ultrasound appears relatively okay. But yes, it is a gray area. And even after a lot of experience, sometimes you are worried. So what I do is, normally in my practice, I like chronic hepatic parenchymal disease needs investigation. Second is chronic hepatic parenchymal disease when I'm sure this is chronic disease. But and third is frank cirrhosis. So that's how I on ultrasound trying to define it. The first is the one which is the gray area, and which will come to a conclusion only after a multifactorial analysis.
Yeah, the point is well taken. So the point is, ultrasound is not a single investigation. It's not for diagnosis. It has to be correlated well with clinical background. That's the importance for a clinician. So it doesn't matter, like, patient has on ultrasound a cirrhosis. It is, that can be easily made out. Only thing is, when we do, because we are dealing from a clinician point of view, when you want to do, so you have roughly a fair idea that, patient has gone into cirrhosis or it's just a fatty liver based on echo texture and echogenicity. The details, I think we need to have a radiology, because we are not going to change, we're not going to report. Like, this is basically to an add-on tool in your practice. That's the point. The point here is, we are not going to teach ultrasound so that you practice radiology. It is going to supplement our clinical decision and also help us in EUS. That's the point. And there is one question, they said, caudate lobe, can you once again tell us about how to identify the caudate lobe on the left? Like, you already told about that. What is the, how do you identify caudate lobe?
Actually, segment 1 is the best way to identify it on ultrasound is what you do. I was showing you the left lobe assessment in the long axis, where you see the aorta and then the IVC, sweeping it from left to right. Now, once you've done this basic sweep, then you turn the probe at 90 degrees with in the just from the so the probe from facing 12 o'clock, you turn it anti-clockwise. So now it faces the 9 o'clock position, right, the upper end of the probe, and then you move up and down rather than going left and right. You sweep up towards the heart and sweep down from the heart towards the pancreas over the left lobe. So when you've gone down low enough, just before the porta, you will be able to see the caudate lobe. And if you go through the video, because now it is recorded, so if you go to the presentation again, you will see I have got caudate lobe at multiple places, and there's a video also. So these are all done in a transverse plane over the left lobe. So left lobe is the window, and through the left lobe, you see the caudate lobe, and that is how. And I think if you go through the presentation again, you will be able to make out. So left lobe in transverse axis is the plane or the window which will show you the caudate lobe which lies behind it.
So there's one more question. What are the parenchymal changes or what changes you expect when you have a hepatic venous outflow obstruction?
Hepatic venous outflow obstruction. Okay. I'll be taking up the cases of congestive cardiac failure subsequently also.
Okay, fine.
Ultrasound is the best modality. These veins tend to enlarge. Venous outflow obstruction, if it is due to IVC or congestive heart failure, causes the heart, then the veins tend to enlarge and the IVC tends to enlarge. And there is so beautifully demonstrated in ultrasound. I mean, a lot of these patients, they have, and you'll get them in practice, they have circulated around for hepatomegaly without knowing, no one has identified the cause for this hepatomegaly. And they've gone to one place to the other, and there's significant hepatomegaly, and they have come for ultrasound assessment for hepatomegaly. And when you put the probe over the left lobe, you see a big IVC, and the cause was somewhere else. And this guy has been these type of things happen to all of us in our practice. So CCF, congestive cardiac failure, the best and the easiest and the quickest modality is ultrasound on earth. You put it, you know it. Second comes when it is Budd-Chiari syndrome of various types. So Budd-Chiari syndromes, I've got few cases. Subsequently, I'll be showing. What happens is Budd-Chiari actually three basic things. And we don't, for discussion, we'll have it later subsequently. One is attenuation of hepatic veins when they are reaching close to the IVC or within the IVC. Second, hepatic veins do not have echogenic walls like portal radicals I showed you. In Budd-Chiari, many of the hepatic veins or the radicals will tend to have echogenic walls. And third is you get veno-venous anastomosis. So you have veins. Hepatic veins, are you seeing that picture again where you saw the transverse sweep, the three hepatic veins like this? They are all aligned towards the IVC. But in that case, the alignment changes and they are in the other direction also. So what you see in the other direction is actually veno-venous anastomosis. So this is what you get in Budd-Chiari syndrome. So we'll be showing those cases, both CCF and Budd-Chiari subsequently.
Yeah. I think the other few questions from are morely for pathology based on disease, so which we will be taking up subsequently. I want to tell my viewers that we will go step by step. We are going to be from basics, and then we will be discussing about various diseases and pathologies in both liver as well as hepatobiliary area as well as pancreas. So I think there's one question about segment 8. How to view the segment 8 on few segments they wanted to know. I think maybe you can actually enlighten them.
Yeah, actually segmental anatomy of right lobe becomes difficult on ultrasound. Left lobe segmental anatomy I have shown because it is relatively easy, and because segment is one big one in the middle, and segment 1 also comes in. But because the right lobe, whole of it is seen, and you are seeing it in multiple sections, and a lot of times you do not know the precision of the section, because in CT, what happens is that you are getting in only one section, fixed, all patients. So you can easily point out the lines, but ultrasound is real time. The probe is moving, and slight movement, as I said, can change the whole window, because the movement may be short at the surface, but because it is sweeping deep inside, movement inside may be much larger. So for segments of right lobe, lot of times there is confusion. But obviously, ultimately, you will have to do with your approximate idea. It's a big approximation. You can never be 100% sure. Because like a CT scan will show you the venous anatomy clearly, and very precise sections are there. Ultrasound, because you are sweeping, moving, and how much slight movement of probe and the image down there is very different. From the right lobe of liver, you are seeing the left lobe, and it can happen with ultrasound. So that's why it becomes difficult to precisely talk about 5, 6, 7, and 8. But it's just that 5, 6 will be, as you know, in the approximate location, and 7 and 8 will be there. So higher up you go, this is 7, 8, and I'm looking down, and lower and inferiorly you are going, you can imagine this 5, 6. So it is just that it's an approximation on ultrasound.
Okay.
Whereas on left lobe it is quite precise, as you saw in that presentation.
I think the last question, I think we have crossed 8 o'clock. So I think one question is the best view for hepatomegaly. What is the best, view?
Best view.
Where do you...
Yeah. This is the first image that I showed, where you put the probe, turn the probe on the patient on the right, elevate his head, hold the probe in the long axis, and put it in the anterior axillary line. You'll see the ribs, they will cast their shadows, but you will see the upper and lower margin of the liver. And that is the best place to assess. As soon as you put the probe there, and you've seen a reasonable number of livers, you will know this is hepatomegaly. And so that is the best view. But only problem with this view, as again I had discussed, is that this view only covers right lobe. So we all should have seen left lobe, then you see right lobe through this, and then you compare and then come to the conclusion.
Okay, sir. Perfect. I think you've covered almost most of the basics, which I would like to know, all the questions you have covered actually in your slides. And few of the pathology and diseases, I think we'll be taking up subsequently. The idea was that way. And we will be moving from the masterclass series class 2 to class 3 after maybe we'll tell us shortly when you're going to do the next along with the topic. And I think that's the basics. We are moving in the right way, sir, starting with how to hold a probe, how do you scan the abdomen, and what are the axes. That is important for us initially for a beginner physician when we have an ultrasound in our department, at least in gastroenterology department, where we can see our own patients, admitted patients. We are not going to replace, the message is very clear, we're not going to replace the reporting for any routine patients. It is basically to help your clinical decision and also people to start EUS practice. So we want to sensitize them. That's the idea of this class, not that we are going to do ultrasound abdomen. Fine. Okay, the point is very clear. It has to be kept in mind because we have a well-trained radiologist and a very good department at most of the hospitals. So it's their job for reporting. But when you have your own patient in your clinic and you have an ultrasound machine, instead of doing routinely every time, you don't have to send a patient for an ultrasound report just to look for an SOL or like we said, portal vein or a fatty liver. You can do your own ultrasound for your patients, inpatients, or your OPD clinic. So that's the message. And I think we will be doing many more classes with basics and then going on to a disease specific, and then lastly translating into an EOS practice. I think we will have few more classes coming up. I think Sachin, anything else? Or we're going to wind up?
Close.
Yeah.
Mahesh will close from our side.
Fine.
Yeah.
Yeah, Mahesh.
Yes, sir.
So
Good evening, all of you. Shall I go ahead?
Yes,
please.
yes, Mahesh.
Good evening, all of you. On behalf of Zydus, I, Mahesh Marathe, take this opportunity to propose a vote of thanks and acknowledge the contribution of those who really worked hard to make this event Masterclass Series 2 on basics of liver ultrasound a grand success. We are immensely thankful to our course moderator, Dr. Shiran Shetty, for conceptualizing and making this entire event possible. Our sincere thanks to our expert speaker, Dr. Amit Pathak, for taking out time from his busy schedule to be with us today this event. Sirs, indeed, it has been our privilege to have you all for this event, and thank you for enlightening us with your knowledge, experience, and expertise in understanding the basics of liver ultrasound. Last but not the least, I would like to thank you all participating clinicians without whom the event would not have been possible. It goes without saying that we will continue to rely on your affection and support now and hereafter. Good night and see you soon again. Thank you and stay safe.
Thank you, Mahesh. Thank you, Sachin.
Thank you so much. Thank you, Dr. Mr. Mahesh. Thank you, Mr. Sachin.
Thank you, sir.
Thank you, sir.